from undergraduates' point of view, because very often these things are asked either in the viva or sometimes they can be of immense use when you write an essay to clearly describe the investigation required, and in the investigation what findings you see. For example, in a case of achalasia cardia or a CA esophagus, so there are key important findings which we have discussed several times on. By the time we finish the 21st module, I think you are all well versed with most of the science, and I'm very, very sure about that. But still, it is nothing like put you on the spot trying to see whether we can interpret the way the examiner wants. So this is more like a final revision for most of you. For newcomers, it could be the beginning of what they have to see and also revise before they go. So in the next two or three classes, I'm going to see today, probably the next Sunday, the following Sunday, I'm going to show you some pictorial representation of some short cases, some key long cases, so that they also, when you come across that case as your case for examination, you should not have any hesitation how to describe a patient presenting with a small cystic swelling in the upper arm or somewhere in the scalp. Is it a sebaceous cyst or is it a lipoma? Something like that. So spotter. So you have to take only about maximum of 3 to 5 minutes to come to a conclusion. And if you are given a case of varicose vein or a hernia, how to examine? There should not be any ambiguity. Go systematically. In other words, all the common things we list it out. Like for example, today common X-rays. Next week or so, common short cases. The following week, the commonly asked long cases. So if you just see that with the background of all the theory we had in the last 20 classes, you will be able to address that without referring to any major books. That's our challenge. Okay. What I need is your freedom or a confidence to express to the examiner. There is no point in knowing but not communicating or not able to communicate to the examiner efficiently, emphatically. You should be very, very bold, eye to eye contact with the examiner, so that you are control of yourself. Don't fumble, don't hesitate. Hesitation is the biggest enemy for all of us. Okay, so you be calm. So I'm going to ask one or two some X-rays, but if I ask you, if you know the answer, you tell me by unmuting yourself. Otherwise, don't worry. I'll just immediately, after waiting about 10 or 15 seconds, I'll go myself. I'm not going to ask second or third person. So like that, we are going freely. So it is up to you to answer. Otherwise, I'll just carry on till the last 5 slides where there is a prize question, something like what, where you can take your test like a NEET examination. So with that little mini introduction, let me go into the first, to the topic itself, like what we did in the last 21 classes. It's going to be problem-based approach. I am going to put the common X-rays for undergraduates, plain X-rays, ultrasound, CT, MRI. Then you think like a surgeon and give your answer. Okay, that is what we need to do. When you see an X-ray right in front of you, as I'm posing it here, the first important thing you should anticipate either from the examiner, or you may politely ask what is the patient's symptoms are, like that. Background clinical detail is very, very important to make a diagnosis. You may be the excellent pathologist or a radiologist, but still, if you're not provided with the enough information, you can't make a diagnosis, can you? For example, if you're going to show or read a barium swallow, then you ask a patient. So patient age has prime symptom. If I say this is a 60-year-old man, has dysphagia for solids, presented to us, and after clinical examination, we did this barium swallow. This is that X-ray, doctor. Tell me the diagnosis. Now you know what you look for. Is it a case of carcinoma esophagus? Because the history suggests that. If it is there, findings are staring at you, you tell the findings and tell. But don't go by the clinical details alone, going for the diagnosis. Why this background clinical details are important, I'll tell you. There are occasions where the radiology will show two lesions. One, the lesion for which patient has come. Number two, incidental finding or innocent bystanders. Say, for example, a patient with a pancreatitis. Okay, that is the main thing. He came with upper abdominal pain, radiating to the back with hypotensive shock. He was in emergency. He had a CT scan done. You do a CT scan. If the CT scan done might show in an incidental renal cyst, or even if it is a lady, a 4 centimeter ovarian cyst. But you should not jump into whatever is striking you, but you should go by the background information provided, and you look in the appropriate area, exclude the main diagnosis, then these bystanders are additional diagnosis. Sir, incidentally, this patient also found to have an asymptomatic or a innocent or a incidental renal cyst or ovarian. What will you do with that? If they say probably that has to be kept under follow-up. So that is a very, very important thing. That's why we always go first step in the direction of interpretation is having a clinical details heard from the examiner or seen from the case sheet. And next is when they show you an X-ray, immediately you just look at the X-ray and say it is a barium swallow or a barium meal or a barium enema or a mammogram. Name the investigation. Very important. First important thing. Don't fumble that. So you should have seen plenty of this investigation. By the time they see, oh, I know that investigation. There is a T-tubal angiogram. See, that is the thing. The success depends upon the swiftness with which or the quick way of responding to the question. Don't waste on these basics. Next is immediately you see whether the patient's name is written and if it is the right patient. If the surgeon says this is a 20-year-old lady and there it is given writing Muthuswamy male like that, then you can start. This is a, says the patient name is different, sir. I want to clarify. Then surgeon, realizing his mistake, he will appreciate that you are going in a systematic way. So always correlate whether the investigation is of the right patient and the right age group. Put it in the lobby in the right way. When I say right way, the right side is the top corner. That is at the 10 o'clock position. If you see the lobby as a clock, at 10 o'clock, there the top left, that there it should be the right side of the patient, because you are seeing the patient from front. It is not this side, right side. This is on this side from the patient's point of view. Okay, so that is very, very important. So you have to treat the lobby as a clock and put the thing, and accordingly you address. For example, from now onwards, if you put a CT scan in a lobby, a big CT scan picture, cross-sectional picture, what you see at 9 o'clock in the lobby is on the patient's right side. What is the 3 o'clock is the patient's left side. So that you should know, because patient is seen from the feet. You are looking at the patient, the cross from the feet of the patient. So these are very fundamental things. We take things for granted, but you have to go into this basic. So put the lobby, because the commonest mistake people do is very fumble when they are given a mammogram. How to put the mammogram? A medial lateral view or a, the superior to inferior craniocaudal view. Like that, there are various views in a mammogram. You have to put it in the lobby, X-ray lobby in the right way. That itself will tell the examiner this job, the candidate knows what he is doing, because he knows investigation name, he put that in the lobby correctly. 75% of the surgeons will pass you if you did the first two steps. That's why I put it in the blue. The next, of course, is if you know the diagnosis, well, the other things are for postgraduates. They have to describe in an orderly way. Like, for example, chest X-ray, I am sure physicians would have seen orderly. You go for the bony landmarks, then the lung fields, upper zone, mid zone, lower zone, like that, you have to describe. The same way, there is an orderly way for abdomen, like any abnormal calcification, soft tissue shadows, any calculus within the kidney, ureter, or is there any gas, abnormal amount of gas within the lumen of the bowel, like intestinal obstruction, or outside the lumen of a bowel, like a gas under the dome of diaphragm. All those things we look for. Then the terminology you use should be the same what radiologist describes. Very, very important that you learn, not a single day. You need to read very many radiologist report as a CRRI or a postgraduates. But even now it is not too late. When you go as a final year and catch hold of any investigation report in the ward, don't read the last line. Read the whole report, because in the report, the radiologist would describe echoic lesion, hypoechoic lesion. Whenever he describes ultrasound, that word echo will be keep on echoing. Okay, you use that word. Second, if it is a CT, you'll say it is a radio dense lesion or radiolution deposit. Like that, he'll be using a radio, that word. Okay, so this is or isodense, hyperdense. If he is using a contrast, and as you give a contrast, when I say isodense means it is as dense as a normal soft tissue nearby. Like if it is a tumor in the liver, isodense means it takes same color of the liver. Whereas hyper intense lesion is it is takes all the contrast. It is more bright white. If it is hypodense means it is black in color. So because it's the shades of gray we are reading, it is not colorful. Color CT, color MRI are on the horizon. It will take few more years to become a practical one. But now as of today, we only see a gray, black, gray pictures. So gray shades of gray we need to read by using all this terminology. So speak like a radiologist. For that, at least you read about 10 or 20 radiologist report when you go for the war rooms. Final is the diagnosis, but to pass the examination, if you say the diagnosis, the examiner will take you what are the differential diagnoses. If you satisfy him, you have a clear pass. There is no problem with that. But this is the way we would like each and every one of you, we are mind trained, because they immediately ask, okay, you said it is a CA esophagus because the patient is having a rat tail appearance, the barium swallow, doctor. What are the next investigations you do? You can tell either a CT, because it will give you a staging of the disease like a T, N, M staging, or even you can tell more specific investigation like doing an endoscopy, have a look at the lesion, take a biopsy, tell and prove the diagnosis. So either way you are right, and whichever way you tell, at least the examiner will know that you are on the right track. Because very important thing for all of us as a surgeon or a senior people to know the youngsters, they think in the same way we would like them to think. Because reading from the book is one thing, applying it to a patient or a clinical scenario is second thing, an orderly way of doing things according to the current scenario, current economical condition of the patient or the system you are working with. In a, I mean, big institutions like a government institutions, corporate setup, or you are working in India, working in US, UK, the order of investigation differ a lot. So you should know that particular area where you are working, whichever hospital you are. Your way of thinking should be the professor or a seniors under whom you are getting the advice. So it's very, very important to know all these things, okay, to understand how we go about it. So let me go. I'm going to show you, I'm sure with all your cooperation, a glimpse of all these x-rays quickly, one after other. And if I necessary, I call one or two you by name, but don't get intimidated. If you are able to give an answer, fine. But if you don't answer, leave it. I'm going to answer. Don't anybody else answer, because others will have your own chance, because too many noises will make complaint. So whoever name comes now onwards, if you feel confident, comfortable, unmute and answer. Otherwise, you just remain silent. I'll carry on. Okay, that's the game plan for the today. Here is a patient, a 40-year-old patient came to the emergency 2 days ago with a severe abdominal pain, and he was in hypotensive shock, and he was resuscitated, then subsequently taken to theater and operated. And this is an X-ray we had pre-operatively just before he went to the theater. And this X-ray is an X-ray chest, as you know. Okay, that is the background information. I asked Bharat whether he could see what you can read or a diagnosis, Bharat.
Sir, I can see air under the right diaphragm subnormally, sir.
Right. From what I say from the history, what did you understood? I mean, before you even start seeing the X-ray. See, I said That is a case of acute abdominal pain. So any acute abdominal pain, you have to think whether it is a peritonitis. If there is a peritonitis, you are suspecting whether it is a viscous perforation. In a viscous perforation, you want to have some extraluminal gas, preferably under the dome of diaphragm. So as I started describing, you immediately, I am sure, even before I asked you, you were looking at the X-ray, didn't you? So you were able to see this extraluminal. What is this sign called, Bharat? This
Sir,
is,
I'm not sure of the name, sir.
yeah, that is actually called a crescent sign. Actually, this is actually a big amount of air. Sometimes air under the diaphragm will be like a third day after your, dark moon. That is we say moondrambrai, isn't it? Like that, it will be very sliver of gas. Will be there. But here it is a large amount of gas. Even as a beginner, you cannot mistake, and usually seen better in an X-ray chest erect view rather than X-ray abdomen erect view. That is a rule number one. Second, it is better and more commonly seen below the right dome rather than the left dome. Because right dome, you have a clearly the soft tissue shade of the liver and the diaphragm are very clearly distinguished. Whereas here, the left dome with the fundal gas will get you confused. But if it is a large amount of air, you will be able to see. So that's the second thing you should know. So very well done, Bharat. I think this is the thing they'll ask you. If they ask you in what percentage of the people you will get air under the diaphragm if they have a case. For example, you tell me what are the common cause for perforated viscous. If I ask you, can you unmute yourself? Try.
So, yes, sir. So any ulcerations, sir, or
Duodenal ulcer perforation. Good. Next.
then any tumors, sir, abdominal tumors.
Tumors going for a perforation is very rare. I'll enumerate, recollect for your help. There are 4 common conditions you never forget. One, of course, is a duodenal ulcer perforation. Second, in our country at least, is a enteric perforation, small bowel perforation due to something like a typhoid. Third, appendicular perforation. Even though appendix as such, gas and the diaphragm is less common, appendicitis is quite common. So you never, always try to include appendicular perforation. So one of the reason, not a common reason. The commonest reason is duodenal ulcer perforation. Take it from me. And the fourth, of course, in abroad, especially in UK, is a diverticular perforation. Sigmoid diverticulosis going for perforation. These are the 4 common causes. There are a humpty number of causes like a traumatic perforation thing. But this, if you tell at least 3 or 4 for the examiner, he'll be happy. Next, of course, is whether duodenal ulcer perforation patient will have gas under diaphragm in all cases, or some cases you will miss if you ask. 80 to 90% of them will have this finding, but there is a 10% they will not have gas because the amount of gas is so small, it may not be apparent. For that, there are 2 important things you can tell the examiner. I'll put a Ryle's tube. Through the Ryle's tube, I put about 50 to 100 ml with a large bladder syringe. Insufflate the stomach with the air. Presumably, air will come out of the small hole in the duodenum and it will cause that whatever gas in the diaphragm much more clearly visible. That is a simple bedside thing you can do. But a better way, what we do nowadays is do a CT scan. Because even a 1 ml of extraluminal air, if you want to diagnose, the best investigation in this country or anywhere that matter is CT scan. So if they give a MCQ, the best investigation to see extraluminal gas in the abdomen. Watch my word, extraluminal gas, the best investigation, X-ray chest, CT scan, MRI, ultrasound. Which one you will take, Bharat, now?
So CT scans.
That's right. See, there is a difference. What commonly done, but otherwise, it doesn't mean that you do CT scan in everybody. If X-ray is negative, you go to the CT scan. That is a message I want to give you loud and clear. Okay, these are the common causes for perforation, and this is what I am just mentioned to you. Okay, good. And this one is very obvious, isn't it? Air, large amount of air, both under the right dome and the left dome of diaphragm. This usually happens whenever you have a small bowel, large bowel perforation, because large bowel is full of gas. So even if you have a small hole in the large bowel, sometimes you have a voluminous amount of gas outside. Okay, this is, but the amount of gas is not directly proportional to the size of the hole, but nobody has done. But it only makes the diagnosis much easier. That's all. Okay. And there are other additional signs sometimes present. For undergraduate, it is enough to know the names of the signs. Interpretation is for the headache for the postgraduates. Like, for example, if you have a patient who is so painful, he cannot even stand or sit to take an erect view. So you take a supine abdomen. In supine abdomen, can you find out extraluminal gas? If somebody asks you, sometimes there are indirect signs because gas is inside the bowel, outside the bowel in this patient, because it's leaked already from a hole somewhere. So because of that, the bowel wall is very clearly delineated everywhere if you see like this. So this is the one important sign we call it, isn't it? Another important thing we say is, in a child in particular, the gas is so much extraluminal, it actually clearly line the peritoneal cavity like this. So these are the two classical signs we described in the perforative peritonitis. That, Bharat, to complete your mark from 80%, you already scored. To make it 100%, can you try now? What are these two signs known as? Unmute yourself for a final time. This is actually regular sign, and this is football sign, because it looks like a football, and this is the regular sign. So these are the two additional signs. I think if you have done this much, Bharat, I am sure you will be very happy that you can clear. These are all the additional bonus mark or prize exam questions, by the way. Okay, so that's about the thing. But there are a lot more things you can learn from the X-ray chest. The X-ray chest is not only for physicians. Surgeons, we do X-ray chest for various reasons. One, as a pre-operative investigation to look at the patient's pulmonary status before submit them for anesthesia. That's a common reason we do X-ray. Second, there are some intra-abdominal conditions that can cause some finding in the X-ray. Last class itself in the trauma, I have said Humpty number, because when a patient comes with abdominal trauma, he can have an associated chest trauma also, like wide mediastinum, ruptured diaphragm, fractured ribs, flail chest, all those findings you try to recollect. Like that, here is one patient came, 10 days history of fever, okay, and pain in the right upper quadrant, chronic alcoholic. He came, and this is the X-ray chest taken, following which an ultrasound abdomen also done. Ultrasound abdomen showed a large collection in the liver. So this is the thing. I'll ask if Jagan Niti is happy to give the answer. Try at least from the what I said background information. Yes, Jagan.
Sir, that is elevated right me diaphragm, sir.
Very well done. So if you see, normally most of us, which diaphragm is raised? Right though, but usually it is not this much. Okay, so that you should, first of all, you should realize this. And but here it is very much because of the either hepatomegaly or there is something between the liver and the diaphragm. One of the thing is, what could be between the diaphragm and liver in a patient with a fever? Fever is a sign of infected collection. Take it from me, especially for a surgical person. Infected collection for you as undergraduate is always an abscess. So if there is something liver, I said, so it is a ruptured liver abscess or a subphrenic abscess. If you tell these two diagnoses, like amoebic liver abscess ruptured or subphrenic abscess or subdiaphragmatic collection causing sepsis, so causing fever. If you are able to tell that, the examiner will be very happy that you are in the right track. But if you are able to interpret raised dome of diaphragm and staring at the X-ray a matter of few seconds, that is excellently done. Coming to this particular one, this is another patient. Okay, came. This is actually patient came to a surgical ward, referred from physician, saying that this patient had a history of trauma 1 month ago. Okay, now patient came, presented to the physician, pulmonologist, with the respiratory distress, that is exertional dyspnea, and he was listening to the chest, and there was hardly any breath sounds, absence of breath sounds on the left side. That is some hyperresonance on the left side, and the right side is okay. He could hear the heart sounds more towards the right side than the left side. So this is the finding they have written, and they send the X-ray to me. Then I am seeing the X-ray, and Ajit Kumar, you are also seeing the X-ray with me. So what do you think probably this patient is having? Can you try to unmute and try?
Diaphragmatic hernia, sir.
What made you to tell diaphragmatic hernia?
Sir, left-sided diaphragmatic hernia, air intestines with air-filled intestines in.
So you can see, I can't see any lung markings here. Okay, normally you want to see something like this on this side. So absence of the lung markings on the left side with a mostly density with some abnormal gas filled, okay, loops are seen, looks like a bowel loop, to be confirmed by further investigation. That is the ideal way to describe non-committally. I couldn't clearly see the left dome of diaphragm. Okay, so no diaphragm, left diaphragm is not clearly delineated. Abnormal gas-filled loops are seen. Normally, what I see, the lung fields are apparently missing. So I need further investigation. And here is your further investigation, Ajit. Then what will you see on here? What is the investigation done here? They have done some sort of barium. They have given some barium. So what happened? What do you see here? So you can see the barium gone into the esophagus, into the stomach and various parts of the bowel. And as it travels the bowel, because the bowel, part of the bowel is within the left hemithorax, I can see quite a few loops of intestine in the left hemithorax as suggested by barium filled shadow. I can see. See, this is the one simple thing. But there are even simpler tests, like even if you put a Ryle's tube to a patient, the Ryle's tube will be seen coiled in the left hemithorax, but there is a vague test. But this is much more sensitive test, or even a better test would be this CT set, where you can see the left hemithorax is filled with what is normally a content you see in the abdomen. Okay, even a spleen, intestines, transverse colon, everything is gone in, and there is a collapsed lung at the top. So this is very, and you can see the kidney. And this is actually a coronal section. We'll come to that CT in a minute. This interpretation may be a bit too much for you, but just to tell, you don't make a diagnosis, stop with that investigation. Because before surgeon takes any patient to theater, what he wants is not 90% accuracy. 100% we need to be sure what we are dealing. For that, if there is an element of doubt in your mind, we have to offer the patient further investigation. It could be simple investigations or could be more investigation. But when you how to decide which is, investigations are basically classified as invasive, non-invasive. For example, if you put some tubes or something like that, invasive, or there is invasive investigation. Like if you do a endoscopy, that is an invasive investigation. But if you do a MRCP or MRI or a CT, it is a non-invasive. Patient just lies in the couch. It just takes a photograph. So it is a very simpler investigation, non-invasive investigations, less expensive investigation as a first line of investigation. Then only you go. That is the systematic investigation profile. Don't jump into the bandwagon immediately, you say. Because as an undergraduate, they say, don't be in a rush to go. Don't outsmart the examiner. That is very important. You have to always show little bit of that as if you are below the examiner. If you just say you are smarter than the examiner will ask you smart question, pull you down. Be careful. Okay, there is a piece of advice for you, Ajit. Then let us go to the next thing. Here is the next important thing we have discussed, especially when we had a patient in the small bowel diseases. See, for example, this particular patient actually came. This is a 25-year-old lady who had cesarean section. Then after that, some ectopic, some operation, 2 operations already been done in the past, presented with severe abdominal pain, central abdominal pain, bilious vomiting. She came and I examined the patient, had a distended abdomen, soft bowel sounds were increased. So we had to send the patient for X-ray abdomen supine. That is the one what you see, and X-ray abdomen erect. So with that background history, with this X-ray staring at you, Ragadarshini, can you try to unmute and see whether you can try give your answer to this if you want to?
Sir, I don't know, sir.
No problem. Mohita, would you like to try? There is no problem at all. Here is because this particular, yes, your Mohita, we are waiting to hear from you. Whatever you say is welcome. Yes, I can't hear you. You are unmuted. Yes, let me just talk for yourself. This particular patient, the supine abdomen, what you see is centrally located multiple loops of small bowel. Okay, this is what we call a typical step ladder pattern. The second thing in the is erect film. What you see is a gas-filled loops of bowel with the multiple fluid levels. If you see 1, 2, 3, 4, 5, 6, 7, 8. If you start counting more and more, 9 multiple. So if there are so many, more the fluid level, more distal the obstruction. But what is strikingly absent is obviously the large bowel shadows are not very clearly seen, even though here there is a confused shadow over the shadow, fecal shadow, but I think it is predominantly small bowel. I put the money on distal small bowel adhesion. Any patient with a previous history of laparotomy, whatever may be the cause of the laparotomy, is a adhesive small bowel obstruction, probably ileum, because the multiple levels, more than 5 or 6 levels, ileal obstruction, 3 to 5 levels, jejunal obstruction. There are only 2 levels, then it's a duodenal obstruction, like a double bubble sign in a case of duodenal atresia. See, like that, you need to have a very clear understanding. Here is another case. What you have to describe to the examiner is, I can see a centrally present at least 2 loops of small bowel. Why you say it is a small bowel, they'll ask you immediately. Then you have to tell, sir, I am able to see the mucosal folds running from the mesenteric to anti-mesenteric border like completely like this. And the distance between them are equal mostly. So these are all called mucosal folds or circular mucosal folds or valvulae conniventes. So valvulae conniventes are present the equal distances like that. And even though they look very big, they are not large bowel, because large bowel, they have only ostrations like this. They don't go full from one way to the other side. So they go only 1/3 to 1/2. Okay. Ostrations are not complete. They are incomplete. They are irregular. Okay. And also they are peripherally located. Cecum, ascending colon, transverse colon, descending. Here it is centrally located. Central location. Second is a circular folds, that is valvulae conniventes, makes it clear. Even without contrast, I can confidently say it is a small bowel dilation. And that amount of dilatation is a sign of a small bowel obstruction. Either you can very easily, confidently, you can tell. Okay. Next, this is a very classical one we have seen in a patient before itself. A patient presenting, elderly man presenting with a severe abdominal pain, gross abdomen. His abdomen was so big. If it is a female, you would have said it is a twin pregnancy. And is tense, tender, hyper-resonant. That is the finding clinically. And you do an X-ray, both supine and erect. Supine and erect. So what is the possible diagnosis? Karshini, would you like to try this particular finding and the particular sign? We have said several times in the past also. If you want to see and tell, you can unmute.
Sir, sigmoid volvulus.
Good. That is the diagnosis. That is what the sign is called, named after.
Coffee bean sign.
Good.
Bent tire sign.
Yes. And one more sign, if you know that, makes it 90% you got it.
Omega sign.
Omega, one more sign then. The sign I am looking for is Friedman-Dahl sign. There's a person named Friedman-Dahl sign, I told you. That is the Danish fellow. So this actually, if you see, there are 1, 2, 3 lines, they all converge here. So this is a Friedman-Dahl. This is actually inner tube, bend inner tube sign, or This is what we call a coffee bean. Sometimes they are more horizontally located. They are like a coffee bean sign. So they are all three names described for a single loop, single large gas-filled loop centrally occupying the abdomen. Okay, and it looks like a coffee bean or a inner tube, whatever way you describe. That is a classical appearance of sigmoid volvulus. Sometimes there is no need for any further investigation. We go straight for surgery. But if the patient needs further investigation, we can consider two additional investigation. One, if you can give a small amount of barium, you can see that barium will only go to the rectosigmoid junction. You can see a smooth stricture. Or you can do the next investigation, the CT abdomen. So these are the two things you can try. Okay. What is this investigation? This is another plain X-ray wherein you can see a both small bowel and a large bowel dilatation in a patient who had recently undergone surgery. This is a post-operative ileus. So a patient with only small bowel dilatation, pathology. Only large bowel dilatation, some pathology. If both are dilated, especially in a post-operative setting after a major surgery, you think of a condition, dilated gas everywhere. Consider paralytic ileus as a possibility. I'm not telling that is the diagnosis. Okay, so that's about it. Now we leave the plain X-ray of the GIT for the moment. Let us move on to the next one, that is this X-ray only we recently said only last week, so I'm sure it will be very quickie one. This patient present with left-sided loin to groin pain. So what is the diagnosis? Where classical thing presented with the severe dysuria, loin to groin pain. So what could be the reason the patient had? Ajit Kumar, you want to try?
Yes, sir. Sir, line to groin pain is a clinical feature of ureteric stone, sir.
Good. Can you see a stone in this picture I am pointing?
Yes, sir. There is a right side ureteric stone, sir. A radio
Is
of
it right
absorption.
side or left side? That is $1 million question for you.
Sir, left side, sir. Sorry, sir.
Yeah, it's a left side. Where exactly is the stone?
Ureter, sir. At
Why you say it is a ureteric stone? I am telling it is just a calcified lymph node. What did you tell the examiner? Doctor, I think it is a calcified lymph node. Why you say, what made you to tell it is a ureteric stone? Then you tell what?
the course of the ureter is.
Tell me the course of the ureter. That is obviously going to be the next question from the examiner. You have to anticipate the next question. Then you are prepared. So you tell me now, why you say it is a ureteric stone?
The course of the ureter is from the transverse process of spine to lumbar spine.
Tips of the transverse process of the lumbar vertebra,
and sacroiliac
joint, then ischial spine, an imaginary line drawn that shows that this particular T3 onwards from here to here, sacroiliac, is a mid ureter. So it is a mid ureter, and here is upper ureteric stone. So it is more or less a fairly large ureteric stone. Okay, present opposite to the which vertebra? This is fourth and fifth. So you should know which vertebra opposite to the which transverse process. Okay.
Yes, sir.
So you try this with the client. That's why I said patient had a left side loin to groin pain. So obviously left ureter. What about this one? Another patient with a strangery. What is strangery? A symptom of strangery. STRANGURY. Strangery. Or patient says, sir, in the night, I go to, pass urine every half an hour. But when I go to the toilet, only 1 or 2 drops are coming, sir.
Dribbling of urine, sir.
So that is a different. This is an urge to urinate. See, you have intense desire. Urge means intense desire to urinate. But when you go there, there is nothing because you already urinated. Your bladder is empty. The empty bladder is making all this crying noise because it is inflamed. Whenever you have a severe inflammation of the bladder, especially the trigon, it is very sensitive. You have that urge. Okay, urge to defecate is a sign of inflamed rectum, like a proctitis. So cystitis, strangery, and tenesmus you will have in a case of proctitis. Okay, inflamed like ulcerative colitis. So all these symptoms you have to think. And this patient is having what? At least how many stones are there?
3 stones, sir.
So you have to use adjective. There are 3 large stones in the region of the bladder. That is the region of the bladder. Okay, so you can say there are multiple bladder calculi. What is the likelihood of the chemistry? If you send that stones, what is going to be the likely? I mean, it is matter of the material.
Calcium oxalate, sir.
Even though calcium oxalate is the commonest thing, it is usually ammonium triple phosphate stones are common in bladder of this nature. Whenever you see a large stone, they are due to infection, super infection, because of the stasis of the urine in the bladder. Say common cause for stasis of the urine in the bladder is prostatic urethral obstruction in an elderly person. Stasis urine, bacterial infection that causes ammonium stones, triple phosphate stones. Whereas if you have a calcium oxalate stones, usually, not always, usually they are solitary, something like a ureteric stone. This is most likely is one of the commonest cause for radio dense stone is, you are right, calcium oxalate. If you have a radiolucent stone, can you give an example for radiolucent stone, which are not seen in the X-ray? Ureteric stones, what is the rule of 80, Ajit? Rule of 80, I told you once. 80% of the ureteric calculi are radio opaque. Only 20% of radiolucent. Unlike gallbladder, where 80% of them are radiolucent, only 20% are seen in the plain X-ray. So here, plain X-ray, kidney, ureter, bladder region is very, very useful in a suspected ureteric stone. That's the basis. But here also, 20% of the cases we will not be able to see. What are the causes for the 20%? Give me 1 or 2 examples. One is a uric acid stone. Another is a cystine stone. Okay. So that's about the next questions. See, these are all additional interpretation. Next, this is a patient, an elderly person who came with the intermittent dysphagia and a food sticking in the throat, halitosis, that is foul smelling breath. And we did a barium, and this is what we found. What could be the diagnosis here? Anybody wants to give an answer if I ask? You want me to name somebody, or anybody wants to? I'll ask Karthikeyan. Would you like to try?
Zinker's diverticulum.
Yes?
Zinker's diverticulum, sir.
Well done. So this is actually a Zenker's diverticulum. Zenker's diverticulum is due to what? It is a classical description is it a true diverticulum or a pseudo diverticulum? First question. What is a true diverticulum? What is a pseudo diverticulum? A true diverticulum has all the layers of the bowel, like a mucosa, submucosa, muscularis propria, and if there is an adventitia, that also. Whereas pseudo diverticulum has only the mucosa and outside adventitia, nothing, no muscle. So the chance of perforation is high. In which condition? Is it pseudo is more prone for perforation or true diverticulum? Which is more prone, Karthikeyan?
Pseudo diverticulum, sir.
Pseudo diverticulum. So this is a classical example of pseudo diverticulum is our Zenker's diverticulum, which is because of the pulsion. It is called because of the pressure difference between 2 areas. Pulsion diverticulum, otherwise called. So it is actually present in the posterior part of the duodenum. It will be seen, for example, between the esophagus and the vertebra. It is more posterior. It is like this. And sometimes it will very rarely present on the left side of the patient's neck, and the patient just put the hand there to press to empty. So like that they'll do that also. And because it is having undigested food particle lying there for a long time, that gives you that smell, the halitosis. That is a classical description. Pulsion diverticulum. So endoscopy and endoscopic treatment is this particular septum we'll remove. Okay, septotomy, that is called. That is a not for you. Zenker's diverticulectomy, that is called. Zenker's diverticulectomy is done so that instead of 2 lumen, 1 real channel, blind channel, made into single channel by removing this particular part of the septum, that is called Zenker's diverticulectomy. Okay, by using a staple procedure, that is the endoscopic therapy. That is by the way. And what is this, Karthikeyan? In another patient who who come with intermittent dysphagia more for liquid than solid with a recurrent chest infection.
Aplasia cardia.
Yes, this is a dilated, tortuous,
Dead big
and
sign.
sigmoid esophagus with a very sharp, smooth, short narrowing like a beak of a bird. Okay, that is why it is called bird beak sign. Very classical thing. So you have to tell the dilated esophagus. If it is so dilated and bending like this, you can use the word sigmoid because it looks like ostrations, like see sigmoid like. And the short, smooth, okay, stricture like a diving bird. Okay, we say diving dove sign. So it is diving into the water, something like that. In the lower, this is the lower esophageal sphincter. Okay, that's all about it. So this is the next patient is an elderly man presenting with dysphagia for solid, weight loss, and he is now finding it even difficult to swallow his own saliva. Gradually, it got worse and worse. Karthikeyan, what do you think is could be this one?
Sir, CA esophagus rat tail appearance.
Yes, you have to tell the examiner to get absolutely right. I can see a long, irregular narrowing in the lower 1/3 or lower part of the esophagus or in the barium. This is the barium swallow examination. First thing you tell. Then there is a long, irregular narrowing in the lower 1/3, suggestive of what is something like a rat tail, sir. I suspect from the history and the finding, I would offer the diagnosis of carcinoma esophagus. Like that, if you tell politely, examiner will tell you have no room. You answered all the questions he was about to ask you. So that's the way to construct. In other words, you can don't give as much as possible monosyllabus answer. You give a structured answer, so that will give the examiner with one answer, you have the stuff in you. So there is no point, we can move on to the next question. Otherwise, if you say it is a barium swallow, then what do you see in the barium swallow? You say it is stricture, sir. Then he'll ask you, where is the stricture? You say it's the lower end of the esophagus. What type of stricture? You say it is irregular narrowing. How will you describe the stricture? It's a rat tail stricture. Now what is the diagnosis? C esophagus. See, it took him 7 questions to get you the answer. And there is a difference. Whereas you imagined all the 7 questions, you gave one after other, giving a small pause so that if the even examiner wants to interpret, you can give. So that way shows your systematic approach, confidence, and also you know the subject very well. So this is the indirect way. But same way, if you utter it rapidly, like as if somebody taught you, the last student might have given you. So did any of your predecessors gave you that clue? Then he'll try to intimidate you. So try to be very polite, slow and steady, but try not to wait for them to ask each and every question. You go systematically, confidently. When the examiner is interrupting, always stop. Never speak when the examiner speaks. Very, very important, because if the examiner speaks for 2 reasons. He wants additional answer, or he wants you to put in the right track. You may be in the wrong track, you see. So always listen to the examiner. Never talk while the examiner is talking. That is a fundamental rule. Otherwise, it will be seen as a biggest offense, insult to the examiner. That is another little clue or piece of advice. You please take it from me. Okay. This is another case of a corrosive stricture where there is a long, multiple smooth strictures. Okay, very common, but in your level it is not necessary. And here is a patient where patient had a carcinoma esophagus infiltrating into the trachea, so that patient was having coughing because of spillage of the food from the esophagus into the trachea through the tracheoesophageal fistula. So because of that, patient was having problem. And when we did a barium, the barium was going into the esophagus, from the esophagus to the trachea, and giving what we call a barium bronchogram sign. Very rare, and we don't want to do this investigation. Ideally, this patient should have had a CT. Anyhow, this is the interesting investigation. Sometimes some of this can be kept in the prize exam. So this is a barium bronchogram in a case of a tracheoesophageal fistula. One of the commonest cause for tracheoesophageal fistula is advanced esophageal malignancy. You know that, that's good. Another common thing is patient with severe recurrent retrosternal pain visiting 10 cardiologists already, atypical chest pain is a diffuse esophageal spasm, wherein if you give them either a dynamic screen, this is actually what is the screen, as patient drinks barium, you do a cinematograph, that is a one movie of the barium. So cinematography of the barium swallow, if you do, it will give you the peristalsis, hyperperistalsis spasm, looks like a corkscrew esophagus. So corkscrew esophagus is a benign pathology, but patient will come with a severe pain, retrosternal pain. So these are all the few things I wanted to tell you. Next, we'll go into the barium meal. One case they'll ask you how the barium swallow, barium meal are done. That is, we used to ask before. Nowadays, it is mainly a technician's job, but still, as a CRRI, what we expect is you should have visited the radiology room. How they perform this investigation, at least once in your lifetime, you go and see the radiology unit, how they do the imaging, CT scan, how they do the X-ray, some basic things, so that you can visualize. Then you can write half a paragraph on that, especially in theory. Sometimes the role of imaging in GIT, if I want to ask you a vague question as an essay, I can ask you, then you'll be wondering what to write. Now you can write systematically. Role of imaging in GIT, plain X-ray, barium, CT, MRI, radioisotope. In that one, first paragraph, how it is done. Few examples. Paragraph or a table. For example, perforated viscous crescent signs in plain X-ray. Like that, you put it all so that examiner will tick, 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 like that. Whatever you've written, no unwanted words, precise, systematic way, not copied from the book, you get the full mark. So that is the way to impress the examiner. Don't just write like that. Surgeons, they don't like paragraph after paragraph. They need flow charts. They need all the different types of presentations, like a pie chart or a graphical representation, or because our mind like flows. If it is a perforation, what I do. If it is not a perforation, what I do. If it is industrial obstruction, is it a simple or strangulated? Bifurcations. We always do the flow chart. So that way you need to understand. Okay. So it is not only just mug-upping, you have to understand and digest and display in a proper way. Coming back to the barium meal series, here, so a patient is given a barium about 250 ml, a thick paste of barium, which is not uncomfortable. It is not unpalatable, but it's not enjoyable. Okay, it is like a gelsil or eating a antacid, something like an antacid. They'll drink it. As they drink it, either you can take a static picture or a dynamic picture, that is cine radiography. Usually, the right anterior oblique view, RAO view, for the esophagus. If you take this way, anterior or posterior, the vertebral column, heart, everything will mask. So you can't see esophagus clearly. So the view you see is right anterior oblique, RAB view. And whereas the abdomen, as the barium reaches the stomach, you wait for the barium to empty from the stomach to the small bowel. Take every 15, 30, 45, 1, 1.5, 2 hours picture. By 3 hours, the barium has no right to stay in the stomach. If there is a barium even after 6 to 12 hours, that means there is a narrowing of the pylorus, gastric outlet obstruction. So that is the thing. Once the barium reaches a small bowel, it will stay there for about 12 to 24 hours. Then it reaches the large intestine, where it stays there for 4 to 5 days. There is a transit time. So all these times you should know roughly how long they stay in various parts of the bowel. About 3 hours in the stomach, about 6 to 12 hours in the small bowel, maximum of 5 to 6 days in the large intestine. If you have a barium today, if you have a barium even after 2 weeks in the large intestine, that means there is something wrong in the large intestine. See, like that transit steady, peristaltic thing, it usually washes out all the barium by this time. If you have a patient where your senior doctor wants the patient undergo barium investigation, CT scan. Which one you'll do first? That is the other $1 million question. You always do CT scan first, then barium. Why? If you do a barium, the barium remains within the patient's in the intestine for up to, I told you, 5 to 6 days. So they'll mask the finding of the CT scan. You can't do a CT scan if you do a barium today. So if the patient needs two investigation, the order of the investigations would be first CT, then only the barium. That is another investigation, important point you have to realize. So all these are very practical, but essential element of advice I want to give you. Okay. Here is a smooth, narrow stricture in the antrum of the stomach with a dilated stomach, as in a case of a corrosive stricture in the antrum, or sometimes even in a Crohn's disease, rarely affecting the stomach, as in this case. And this is a very classical appearance of carcinoma in the antrum of the stomach. Here, the dilated body and fundus of the stomach with irregular narrowing, or this is the barium, it is going narrowing with the shouldering. Very important thing. This shouldering, and this is actually something like an apple core. You can see this is the apple kept in a different way. It is lying apple rather than a sitting apple in a what I call in a large intestine, where you say apple core means large bowel cancer. Similar thing. You have a small core of the apple as a barium, and this shoulder is a sign that is an ulceroproliferative lesion circumferentially occupying the distal stomach. Okay, that is all the findings you see. And here is a various presentation of the ulcer disease. But I told you already, whenever you have an acid peptic disease, we don't do radiology. We go for endoscopy. Okay, but sometimes those days we used to do a barium wherever there is an ulcer crater. You imagine ulcer is a defect in the mucosa. The barium will be present there like a niche. Niche is a small, so that is there for a long time. Whereas all the rugal folds are converging mucosal folds, niche of barium, and some hyperpulse as a notch in the opposite area. So there is a niche in the lesser curve and a notch in the greater curve. Spokes of the wheel of the rugal folds, classical sign of a like a volcano-like lesion. But these are all seldom done and seldom shown for undergraduates. And here is a large proliferative filling defect, irregular, persistent filling defect. That is another word you master. Irregular, persistent filling defect within the lumen is a sign of large polypoidal tumor. If it is the stomach, it is a gastric cancer. If it is the large intestine, it is a tumor of the large intestine. So irregular, it should be persistent. Why that word persistent is used? Because this particular area is not narrowing. This is the peristalsis. So you have to take multiple pictures. All the picture at 15, 30, 45 minutes all shows this irregular persistent filling defect. Then it is an abnormal defect, isn't it? And coming to the next quickly, when the barium goes in the small intestine, to have a good view of the small intestine, sometimes we give anticholinergics. Okay, Buscopan, that is a thing. So there is hyoscine you are giving. Okay. Next important thing is, what about a clarity of the small bowel? For that we can do one more thing. That is, you put a Rayleigh tube into the duodenum, then give the barium through the Rayleigh tube. So the barium given through the Rayleigh tube, rather than going through the esophagus stomach, it directly enters, okay, into the duodenum, so that large amount of barium quickly travels through the small bowel, so that you can have a clarity in the small bowel study. This is called enteroclysis. The word enteroclysis, otherwise called small bowel enema, is a radiological or a barium examination of the small bowel, wherein a Rayleigh tube placed into the duodenum, we give the barium, into which after that anticholinergic is given. So you can see all this valvulae conjunctis, all this very nicely. And here if you see, there is abnormality. These are all small bowel, this is the large bowel, and this is the stomach, all with the barium at various time. Don't worry about that. But there is a So if you carefully see from the stomach, duodenum very seldom seen, jejunum, here jejunum, ileum and ileum and ileocecal junction ascending colon. I showed everything. Now Bharat, back to you now. Do you see any abnormality in a young chap who presented with a recurrent abdominal pain, diarrhea, and we did a barium and it showed something. The arrow is also trying to help you. What do you call this sign as?
Sir, ileocecal stenosis.
Yeah, it's a long, narrow string of canter. String of canter is long, narrow, smooth structure involving the 1 feet of the terminal ileum. It is common in one condition, that is Crohn's disease. Crohn's disease will give you this. Sometimes similar thing, even if you say ileocecal tuberculosis giving small bowel involving the terminal ileum, there are only two pathologies you should consider. One, ileocecal tuberculosis. Second is a Crohn's disease. But here the classical appearance is Crohn's disease because the the cecum is not involved. In ileocecal tuberculosis, the cecum is also destroyed and it will go further up, fibrosed up, go into the subhepatic region here, subhepatic region. That will give you a different appearance. I'll tell you in a minute. Okay. Here is our next investigation is a barium enema. How do we do a barium? The barium enema is not done by giving barium orally. It is given rectally. That is the first thing you should know. And we put a Foley catheter. You see a Foley catheter in the rectum with a balloon, air-filled Foley catheter here or a water-filled. Then you inject the barium and put the patient head down. So barium goes, fills everything. This is only barium. That is called a single contrast barium enema. Not very good. Whereas in the same, after putting some amount of barium, if you put some air inside, then it is a double contrast barium. Air as a contrast, which gives you an absolute clarity of mucosal details. So the mucosal changes, like if you want to see a small polyp or a small early cancer, which is the best investigation, Bharat? Is it a double contrast or a single contrast? Which is best, do you think?
Double contrast barium.
So double contrast barium is the order of the day. We seldom do a single contrast. So always go for it. Is it very expensive to do a double contrast? No. Air is very cheap. You just instill, that's all. So the technique is modified. So always you look at the X-ray, you tell, exam will ask you, barium enema. Can you tell what type of barium enema? What it means is, you always say double contrast barium enema, sir. Either you tell. Okay. Then in the barium, Bharat, you have two things. Here is a patient with a right iliac fossa mass with the altered bowel habits and elderly people. What do you see? Can you describe a lesion there?
It is a small bowel, sir.
This is actually the whole thing is a barium enema. So barium is going in the transverse colon, it is going this way. It was not able to fill in this portion. A small amount of barium only go and it tries to fill the remaining colon cecum. Nothing. There is no barium here in the small bowel at all. Or it may be small amount of bowel. So it is a barium enema and showing ascending colon. There is a start irregular narrow structure with the shouldering. This is called shouldering, what I'm calling, like your shoulder, right and left shoulder. This is a typical apple. You have to draw an apple here, like this apple, and the central core of the apple, what remains after you eaten the apple. So there's an apple core lesion, sign of a
Humors.
CA ascending colon. You have to be very precise because you are looking at the ascending colon, isn't it? This is ascending colon. If the same thing is here, it will be transverse colon. And here is another patient who came to evening rise of temperature, weight loss, diarrhea, and we did a barium. It shows a barium is going into the transverse colon, ascending colon, cecum, and reflux into the small bowel, also in the terminal ileum. And this is the ileocecal junction. Normally, the ileocecum, ileum, cecum will go and meet here this way. Here, because the cecum is going up, ileum, the angle, if you see in my hand, this is what we call a obtuse angle. What is this angle? This is a right angle. This is acute angle. This is a obtuse angle. So there is an obtuse angle. Why they ask you? Because of the fibrosed, diseased cecum, pulled up cecum. So dropped. So the ileum is dropped into the pelvis and it is abnormally narrowing and filled with barium. So this is the abnormal narrowing and irregularity of the ileum and obtuse angle, ileocecal angle. These are the things classically described for ileocecal tuberculosis. Okay. So you should be able to describe all these findings, at least one or two findings for you to come to a conclusion. And this is a very peculiar investigation we sometimes do these days when a patient is not keen for invasive investigation. Colonoscopy is an invasive investigation to find out whether patient has a polyp, early lesions. And this is a non-invasive way of doing a colonoscopy. This is called a CT colonography. Any name, alternative name for this, Saranya? What is the name given for this particular investigation? This is done with the help of a CT. So this is called virtual colonoscopy. So CT colonography or virtual colonoscopy. So they can tell you even a polyp of about 5 millimeter in diameter, you can see nicely. Okay, and early diagnosis is possible. These are all we have seen only last week. So I am quickly go through for lack of time, and then IVU is done provided the patient's renal function is good. Creatinine should be less than how much? 1 or 1.2. Okay, let me just. So when you give the urographine, okay, after a good bowel preparation previous day and patient kept starved for 12 hours, when you give, the first picture you do is it will give you what we call a nephrogram, that is kidney shadow. Then it will go into the calyces, then the dye will come into the ureter, then it will come to the bladder, and the patient can take a picture before and after voiding, pre-voiding, post-voiding. So this, like barium, also done at 5 minutes, 15 minutes, 30 minutes, pre-voiding, post-voiding. If you tell that, that is enough. There is no need for accuracy of timing. Nephrogram, urogram. This is intravenous urogram because whole urinary urinary system is seen, starting from the nephrogram down to the bladder region. Okay, you'll be able to see the calyceal pattern. You can now see how accurate the description of the ureter going along the path. So if you see any stone along this path only, you say it's a ureteric calculus. Here is a hydronephrosis because of pelvic ureteric obstruction, normal ureter and abnormal obstruction. Here is a duplex system. Sometimes you can have not a single ureter, two ureter. See, upper moiety, lower moiety. Upper pole of the kidney is having a ureter on its own. It is draining lower. So upper moiety usually drains in the lower part of the bladder. The lower moiety goes at the upper part of the bladder. That is one of the rules. You should realize that also. Sometimes they can have problem. So you need to realize whether this has any reflux or any recurrent urinary infection. In all these findings will be very interesting to see. And this is a normal pelvic calyceal pattern. Here it is a displayed or a splayed out. Okay, they are all because of the space occupying lesion in the right upper pole of the kidney because of the hypernephroma. This is the converging calyces, the lower pole especially across the vertebra, and that is a sign of horseshoe kidney. Here is a filling defect in the bladder region. Okay, with the patient with the painless hematuria. This is the transitional cell carcinoma of the dome of the bladder, especially very close to the right ureteric orifice. So like that you have to, and all these people, whenever you have a doubt, next best investigation is CT scan with a contrast. Coming to the quickly about the angiogram. Angiogram is beyond your limit for undergraduates, I know, but examiner might ask you if you have a case of TAO or a case of a gangrene, they'll ask you what test you will do. Then you utter the word angiogram. They'll ask you another thing, what are the different angiogram you know. So you should know at least the name of them at least. Translumbar iotogram or angiogram is a history now. It is no longer done. CT angiogram, MR angiogram is the simple non-invasive investigation. They all done by us. Digital subtraction angiogram is done when you are planning to do some intervention, and I said treatment. In other words, CT angiogram, MR angiogram are diagnostic. Digital subtraction angiogram is for therapeutic reason. That is the main thing, because that will give exactly what you do. Like a cardiologist, before they do an angioplasty, stent insertion, they have to get a digital subtraction angiogram. Okay, that is the first thing. Can you note the difference? Yes, sir. Here, a fine, long needle is inserted directly into the aorta through the loin here and give contrast. Translumbar aortogram. That is only a the museum X-ray. I won't say it is not. 30 years ago, we used to do aorta, common iliac artery, internal iliac, external iliac. Okay, you can all see this is the inferior mesenteric artery, superior rectal artery. It is giving. Okay, this is the inferior rectal artery. Inferior mesenteric artery is one of the 3 visceral arteries: celiac, superior mesenteric, and inferior mesenteric. What are the important lateral branches? Renal arteries. If you know that, that is well and good. And this is the CT angiogram. Very simple. Or MR angiogram more or less will look same way. So you can see the vessels, and it comes to the femoral artery in the thigh, divides into deep femoral artery of the thigh, that is called superficial femoral, which is artery of the leg. The superficial femoral continues through the adductor canal, and as soon as it crosses the popliteal fossa, it goes for a trifurcation, I would say. So what are the trifurcations? It just go into the anterior tibial first, then posterior tibial, and then central one. Always the central one is a peroneal vessel. The central peroneal artery is purely muscular. It disappears into the peroneal muscle compartment, whereas anterior tibial continues as a dorsalis, and posterior tibial continues behind the medial malleolus into the plantar arch. So both can be seen nicely. And this angiogram, CT angiogram, cannot be done if the patient creatinine is high. Then what can be done? MR angiogram can be done. Okay, that's all about the thing. Next, this is what I called a digital subtraction angiogram. What do you mean by digital subtraction angiogram? You have to tell, sir, to have a very accurate image of the vasculature and a road map, and to look at the stricture and stenosis easily. A computer helps us to subtract the unwanted bony elements. That is a very important thing. In other words, first you take the patient's picture with the soft tissue, bone, everything. Next, you give the contrast and take this angiogram. You subtract the first picture, that is a bony soft tissue. So you have vessel, bone, soft tissue. Next, bone and soft tissue, the one you taken. You subtract one from the other, then you have only the vessel alone seen. So in other words, the subtraction of the bone and soft tissue will give you only the vasculature in front of you as a negative image, black image. So instead of the white image like this, where the contrast, will be seen like this. Okay, and there you can see accurately a narrowing like this. And then immediately I can, the same catheter which helped you to do this angiogram, I can put a balloon and do an angioplasty. So DSA is a subtraction of soft tissue and bony elements, and it is for therapy like angioplasty, stent insertion. Repeatedly you keep telling, because this is commonly asked question. What about cholangiogram? If you see the biliary tree also, you can have a road map. The bile duct, pancreatic duct. There are various ways we do, like what I have enumerated here. Quickly I go through because of lack of time. Oral cholecystogram. If you have a functioning gallbladder, this can be done, but this is history book. It's no longer done. Intravenous cholangiogram, again no longer done. What is done nowadays, if you ask me, we sometimes do during laparoscopic cholecystectomy to see whether the gallbladder is clearly delineated, cystic duct is delineated, common bile duct is clearly delineated before we do the complete the procedure called intraoperative cholangiogram. So when you see instruments coming like this, and with one instrument going to this area of cystic duct, that is an intraoperative cholangiogram. Okay. Second thing is, after surgery, sometimes patient will come with a tube like this, like a T tube. The T of the, this is the long segment of the T, and this is inside the bile duct. T tube cholangiogram, post-operatively. Sometimes if the patient has a stone in the bile duct, we send them for an endoscopic examination and a radiological evaluation, then removal of the stone by putting a duodenoscopy. This is called ERCP, endoscopic retrograde cholangioscopy. So this, the picture you have to see, take a snapshot of this in your mind. Then you can tell. So there are various types of cholangiogram. And the final one is this one. What you see in the anatomy class. Okay, there is no instruments or anything. Only the gallbladder, cystic duct, right and left hepatic duct, bile duct, pancreatic duct joining here behind, going actually behind the bile duct like that, duodenum. This is what we call a MRI of the biliopancreatic tree. That is called a MRCP. MRCP is not a degree, you get it from UK. It is a investigation we do day in and day out for any disease of the biliary pancreatic disorders in a non-invasive way using a MRI, magnetic resonance imaging. Okay. Coming quickly to a quick word about the CT scan. How CT, so it is a computerized tomography. Usually in the past it seems to be only cross-sectional image we used to have. That's why it's called a CAT scan. CAT, axial tomography. Now you can have a coronal scan, sagittal scan, so computerized tomography. It can be plain scan or a contrast. When you give urographin or a contrast, there is iodine contrast. Two things, allergic to iodine, or second is a serum creatinine should be within normal limits. Who invented CT and how people interpret CT? You remember this great person's name who got the Nobel Prize? Hounsfield, Godfrey Hounsfield, Sir Godfrey Hounsfield. And the description of the lesions by using these terminologies, if you are able to write one or two lines, well and good. Hyperintense, isodense, hypodense lesions. When a lesion is taking contrast, you can say contrast enhanced lesion, like a hemangioma. When a contrast in the bowel is going outside the bowel, contrast extravasation, it is a sign of a perforation. Like that, the word enhancement, extravasation, all these words, unless you see, is very difficult. I just want to tell you interpretation of CT alone today, because there is too much for you as undergraduate. This is a chap proudly standing in front of his own CT scan, Sir Godfrey Hounsfield. Three numbers you remember today. Hounsfield said, if you see something as white as a bone, like this, all bone will be so white, like a then it is a Hounsfield unit 1000. Okay. If you have air that is just opposite to the so dense white, so black, jet black, that is air. Okay. Water or the CSF is 0. In other words, air can be very easily identified because it has a minus 100. That is, in other words, between minus 100 to plus 1000, so minus 1000 to plus 1000, there is so much of grading in the gray scale. So you'll be able to identify even a small, see, this is the air in the frontal sinuses, something, even a small amount of air you can identify. So very, very easy. Whereas you have a fat, it has a different Hounsfield. It looks like black, but it's not like a, if they have a, see the Hounsfield unit, it will not be like this. It will be minus 30 to 70. So it is very, very easy for the radiologist. For you, it may be difficult. Hemorrhage, how it look? It look little white. That is plus, it will always come more positive. Like there is a lot of things you know, but a Hounsfield unit of bone and is just opposite. Okay. I want everyone to unmute, remain unmute, please. I can see some outside noise. Thank you. So these are the three important views. The coronal plane. In other words, this way. You look this way, you take a section of your body. Sagittal plane, this way, like a sagittal suture, like that. You take a view and look from the side. Transverse plane, which is very often understood. This is the common plane we always see. Okay, see, for example, this is a cross-sectional image of the body. You can very easily interpret. But these two are uncommon place seen for undergraduate. One is this is a one plane. This is a sagittal plane where you can see the from posteriorly, that is vertebra and the anterior mediastinum and the sternum, like that, thorax, and here also the vertebra, liver, and the anterior abdominal wall, like this. Whereas here is a coronal plane. At a given plane, you can see everything, like a diaphragm, lung field, central mediastinum, like this. So it is a difference. In other words, you have to have a bird's eye view, three-dimensional anatomy to understand that or to comprehend. It is not only the job of the radiologist, but you can do some attempt trying to interpret. For example, if I give you any image, you see this is a cross-sectional image. This is a coronal image of the same CT scan. Because that way, the anatomy, what you see, layer by layer, can be put in the CT and you can understand. So next time when you go, or the next generation of the surgeons or the physicians or the doctors will understand the anatomy in a CT perspective, then only you will be able to see. I'll try to help you. This is a cross-sectional image, and always you see this is their patient's right side, 9 o'clock. 3 o'clock is the patient's left side. I told you in the monitor when you put it. Vertebra, aorta, IVC. Okay, this is the in front of the aorta. The first important thing is the left renal vein, and in front of that is the you see another artery. Okay, that is the superior mesenteric artery. Then another vein, that is a splenic vein. So artery, vein, artery, vein. This is a very classical section right at the level of the pancreas. This is one of the commonest picture all of you will be seeing for the rest of your life. And this is the liver, right kidney, left kidney, small bowel loops, stomach with the air and also a little bit of contrast in the stomach. Anterior abdominal wall musculature, fat and skin, okay, all around. You can see this chap is not very obese, looking at the thickness of the thing. Some people will have this about 2-3 centimeters, you can say obesity. And this is another view, coronal section, the stomach nicely, body, antrum, pylorus, nicely seen, large intestine, descending colon here on the left side, ascending colon with the contrast nicely seen, and you can see some diverticular perforation with abscess going to the anterior abdominal wall. See, this amount of understanding you can have only if you have various sections and various interpretations. So you can put the anatomy. So how you make a diagnosis? Anatomy plus pathology is equal to the diagnosis. So where is the lesion? Anatomy. What is the lesion? Pathology. Combine, give the diagnosis. That is same for whether you are a surgeon or a neurologist. CT, as I said, it can be plain and contrast. You sometimes give oral contrast to see any perforation. You want to see contrast extravasation. Okay, and you always take small cuts so that you are able to see any vascular or local invasion, because staging of the disease, whether it is a tumor or anything, can be easily done with a closer section like 5 millimeter cuts. And I told you already, you do a 3D reconstruction both in the cross-sectional, sagittal and the coronal cuts. And even we have got the virtual colonography, I told you already, and also CT cholangiography. The indications I already told you when we discussed it. Wherever there is a patient who goes to the OT, don't send them without CT. Be it an acute abdomen or a trauma or a cancer. Because in cancer, we want to do this, know the staging. In trauma, we want to know whether the patient is actively bleeding. In acute abdomen, we don't want to miss any lesion. We don't want to say the Pandora box of abdomen. That is, abdomen is full of surprises. Those adages or descriptions are before the era of imaging, like 20 years ago. Now, when we go in, 99.9% we go with the diagnosis, because patient likes to know the diagnosis before we open the abdomen. Days are gone where we say laparotomy and proceed. Now we consent. Here is a case of small bowel perforation for laparotomy and suturing. Like that only we make a clear-cut diagnosis before we go for surgery. For that, all this investigation helps. Like here, right kidney, Left kidney, I told you. Right kidney, there is a lesion going out of the kidney, infiltrating. Any infiltrative lesion like this, it is a two things. One common thing is tumor. Second thing is whether it's an abscess rupture like perinephric abscess possible. But here it is a tumor because there is an addition. There is a multiple liver secondaries. Okay. And here is another patient with another pathology. That is you can see a pancreas very grossly swollen, acute pancreatitis. So like that you can have a diagnosis with a click of the button. We have 5 more minutes, so I quickly tell what we need to know about the MRI. If anybody asks you, do you know anything about MRI? You just tell them MRI is everything to do with the M stands for the magnetic, so magnetic field. So patient with the metal objects should not enter the MRI. That is the best measure I wanted to give. So usually they have a metal detector before you enter, but at least you should know this patient has any pacemaker, or whether the patient has any implant like a hip joint or any. You have to tell. Some recent titanium implant, they cannot be a contraindication, but still is important. Or mechanical valves, some valves in the heart. Sometimes those days we have to put some metal valves also. So those people, they are contraindications for this MRI. That is the one important thing, because there is a strong magnetic field that causes spinning of the hydrogen atoms in each and every cell of ours. Once the field is on, they spin. They stop the spin. Magnet field. Then they reorient the hydrogen atom going to the normal situation. So this repeated spinning and stop spinning of the hydrogen atom gives you a picture without even a radiation. Here, the difference between MRI and also CT is a glorified X-ray. So there is a lot of radiation. MRI is no X-ray. So even in a pregnant lady, you can very easily do. But what is the problem? At least until now, this is done where the magnetic field is in a closed atmosphere. Patient has to go inside, deep inside. Even I had one MRI last year, and it is very claustrophobic, I tell you. 15 minutes you stay there with a loud, somebody is hitting your skull with a stone, because it makes you a noise every time. The spinning of this hydrogen atom, because of the magnetic field changing, it gives you a loud noise. Even though they give you something for your ear, plug the ear with a cotton, still the noise is uncomfortable, stay is unforgivable. I don't think you will stay. So the patient has to be really motivated to go into this tunnel. So MRI is done in a tunnel. Claustrophobia is a real problem, but thanks to the open-ended MRI nowadays coming, this problem is less. And also now a rapid sequence MRI, that is we called what is called a Tesla. Tesla is the speed of the machine. So 2 Tesla, 3 Tesla, if the number increases, that means they have the more recent machines. Okay, and I'm sure neurologists will tell you MRI is also a functional MRI. You can tell certain people with Alzheimer's disease some changes. So it is not only a diffusion MRI, functional MRI is also possible nowadays. So there are MRI is the future, especially for a neurologist, and also for us, it is useful in various conditions like MRCP for biliopancreatic tree, breast MRI, especially for a cancer in a young woman with a high family history of cancer. If I want to do a mammogram in a 30-year-old girl, it is a radiation exposure. So I do better you do a MRI of the breast. Or MRI abdomen in some cases may be useful. MRI perineum to look at the fistula in ano are very useful. Okay. The last slide is a role of radioisotopes for surgeons. We inject the patient with some radioisotopes, and when the radioisotope is taken in a particular area, it gives you what we call a hotspot. In other words, that takes all the radioactive material you give. Like if you give a selenium or a sestamine, for example, the sestamine will be taken by the parathyroid. So it will give you what we call a hotspot. That is called hotspot. Technetium scan for Warthin's tumor, or a sestamine scan for parathyroid, like their hotspot. If it is a functioning, it will be hot. If it is non-functioning, it will not take the radioactive isotopes. So then it is called a cold nodule. See, non-functioning nodule. Next is if you give something orally and if it spills outside, okay, then spillage is a sign of extravasation, a GI bleeding. So same way like a CT, here also various terminologies are used for you. If you know what is hotspot, wherever radioisotope is taken, that area will be nicely brightened up when you take a picture of the area by using a gamma camera. So gamma camera gives you a bright picture. That is a hotspot. It is a dark area or a negative picture. There is a cold nodule. These are all the pathology. These are the isotopes. You have a snapshot of this now or later. Very important for you for MCQ. 10 MCQ are hidden here. If you are going to have a thyroid patient like a Graves disease, what scan? Radioactive iodine 131 you can give, or a technetium scan can be done. Parathyroid, sestamibi, I already told you. Pulmonary embolism, ventilation perfusion scan, VQ scan, cardiac function, thallium scan, renal function, especially I want to know which kidney is functioning. Is it right kidney, left kidney in a bilateral hydronephrosis, DMSA scan, okay, and a biliary leak or a cholecystitis, HIDA scan, acetic acid, diacetic acid, but HIDA scan or HIDA scan, we call it, is seldom done nowadays. GI bleed, tagged red cells, look for extravasation. Osteomyelitis, infection of the bone. Nowadays, we do not only X-ray, MRI, but also indium 111 scan. Pheochromocytoma, very, very important for your MCQ. MIPG scan. And if it is a carcinoid, Octrio scan, that is somatostatin scan. Okay, I remember that because if you put some introduction, even if they ask you like a paragraph or an essay, if you put this, exam will give you 50% of the mark. The final thing is the positron emission tomography or a PET scan along with the combined computerized tomography. CT combined with the PET scan is the order of the day for oncological investigation because it is called metabolic imaging. Very, very important. Okay, it is what is metabolic imaging? You give a radio tracer. The one thing required for each and every cell of our body is glucose. So you give them the 5-fluorodeoxyglucose, which is a radio tracer. It is something like your normal glucose. It is taken up by all the metabolically active cells. Cancer cells are more metabolically active, so they take up more cells. So they are brighten up like a hot spot. It's very, very important in a patient with lymphoma, Hodgkin's, non-Hodgkin's lymphoma, CA breast. Okay, I think that finishes right in time. And because of lack of time, quickly 5 questions. Let me go through. I want 5 volunteers who wants to give. This is the patient came with swelling in the neck with difficulty with the swallowing portion of the voice, and we did a ultrasound, FNAC. Then the surgeon decided to do a CT scan, a cross-sectional image, and then a sagittal section and a coronal section. You should understand the various sections. Then only you will be able to interpret. Who wants to take a challenge? I would probably require Karthikeyan. Karthikeyan, would you like to give your findings? You can see.
Thyroid enlargement.
Very well. See, because from the history you can interpret. There is sometimes you patiently listen to the examiner and he gives a history as if there is swelling in the neck, giving all these things. So the common things are common. Consider thyroid as a possibility, not the only thing. Or it could be also lymph nodal mass or some nodal. So if you carefully see, it is a trachea. In front of the trachea, there is a large thyroid swelling encircling the trachea and going behind the sternum. As you can clearly see, the coronal section, you can see the proximity of this lesion to the great vessel, isn't it? So it's a retrosternal extension of the retrosternal goiter. So what is the sign you elicit in a retrosternal goiter? For undergraduate, when you do this, there is engorgement of vein in the neck. What is that sign, Karthikeyan? Pemberton sign, isn't it?
Yes, sir.
That's right. Next, Here is a patient who came with altered bowel habits with the rectal bleeding. And we did a, what is this investigation? We'll ask Sai Samhita. Would you like to give an answer? Here is an investigation. Yes, name the investigation. Give your diagnosis.
Double contrast.
Well done. So if you say barium enema, that is only half that. Double contrast barium enema, absolutely right. How they do barium enema? What you have to do before you put the barium inside? What do you have to insert into the patient rectum? A Foley catheter.
Riles tube. I mean, Foley's catheter with the air.
No Riles tube. Yeah.
Foley's
catheter. If you put a Riles tube, the barium will spill out. Yeah. So Foley catheter, inflate the balloon, then put the patient's little head down. Then gradually you give all the barium followed by the air as a contrast. Then take a picture in a various position. Then deflate the catheter. Ask the patient to go and evacuate. Even you can post evacuation picture also you can take, like a post maturation in IVU. Here also you can do. Okay. Here is a one snapshot only I'm giving you. I haven't given you a series of picture. And for lack of time, I've even given you an arrow. The pathology. Can you describe a pathology?
Sir, it's an irregular filling defect.
Yes. What you have to cleverly say is, because I said apple core, you should not use an apple everywhere. So here it is a persistent, irregular, large filling defect. Exactly where? That is the next part. Anatomically.
In the descending.
Yes, it is in the descending colon. So it is a distal. See, this is the splenic flexure, descending colon. Here it becomes sigmoid colon. Okay, so it is a descending colon, and the size is, I mean, for you it is difficult, but always you know the size of the vertebra. The length of the vertebra is about 4 centimeters. So this is about 3 centimeters. So 3 centimeter irregular filling defect in the one lateral wall of the descending colon occupying. And what is the diagnosis?
Probably CA sir.
I mean,
CA colon.
CA descending colon. You put it right. Okay. What investigation will confirm your diagnosis?
Either we can take a colonoscopic biopsy.
Yes.
Or we can go for a CT scan.
Which one you will do first?
Okay. So I'll first take a CT scan and then I'll go for a biopsy.
Why? If you do a CT scan tomorrow, can you do CT scan tomorrow in this patient?
No, sir, we can't do it. Okay.
So you have to wait.
6 days for 5 days.
You have
to wait for CT.
If the patient comes tomorrow with this picture, you tell the patient, because of barium, I can't do any investigation for that matter. You give them bowel preparation. Give a polyethylene glycol. Few days, his bowel will be cleaned up all the barium. Then you do a colonoscopy and biopsy. Then it will confirm the diagnosis. If it proves to be a cancer, next answer you want is what is the stage of the disease? TNM. For that you do a CT. So that is the order. So ideally you should do either ultrasound, colonoscopy, CT. That's what we do. The barium is done only for you as undergraduate. We don't do barium. Just for you and me, I'm telling you. Barium are history, museum. These are all museum X-ray. I'm trying to collect all this X-ray. Okay. Seldom done barium. But you should always know the diagnosis, whether it's a sigmoid or a descending colon, colonoscopy, CT. CA is a tumor marker.
Yes, sir.
Treatment is colectomy. Complication of colectomy is anastomotic leak. Like that, the examiner will start with a simple investigation, but take you to various possible questions. So you should be mentally prepared for all these things. It is not just, in other words, X-rays are placed in the examination only to invite the topic for you. Okay, they are not just asking you just to give the diagnosis and walk away. So it is only, it is like a ward round, glorified ward round they are going to do. Okay, let us. This another patient came with recurrent right upper quadrant pain, fever with rigor. Okay, and we did an ultrasound. Following that, we thought we'll get this investigation done. And I asked Bharat now, what is this investigation we have done in a patient with intermittent right upper quadrant pain with intermittent fever with the rigor, coming with ultrasound showing a dilated bile duct, going for this investigation. what do you see the investigation right in front of you, and can you read it if possible? Bharat.
Sir, contrast of biliary tract, sir, showing obstruction of the bile duct.
Yeah, this is a contrast in the biliary tract, that is called cholangiogram. What type of cholangiogram? You have T-tube cholangiogram, you have intraoperative cholangiogram, you have MRC cholangiogram, and you have a CT cholangiogram, and you also have a ERCP cholangiogram. Which is one? This one?
Sir, ERCP, I guess, sir.
Where is the ERCP endoscopy? ERCP, you should have like a hockey stick. The endoscopy should be there. So you have to, that's why I said, you go back today and see the YouTube, the snapshot of the picture I showed you for ERCP. The
Yes, sir.
endoscopy should be seen like this. Here it is nothing. Only this is actually a typical picture of MRCP. Okay. So
Yes,
this
sir.
is the MRCP showing a distended gallbladder. This is the T2 weighted image. If you want even specifically, there are a lot of things you can learn, but it's too much for you. This is a fluid filled gallbladder, right and left hepatic duct, common bile duct, pancreatic duct, and a little bit of duodenum. In the bile duct, which is dilated slightly, you can see a filling defect. So it is a stone in the bile duct, Charcot striate, stone in the bile duct. So he is a typical case of choledocholithiasis. That is the diagnosis. Okay, Bharat?
Yes, sir. Yes, sir.
So that's the thing. And this is the another one. We are starting from where we stopped. Another interesting X-ray patient with acute abdomen. So what is the diagnosis here? Karshini, can you make a diagnosis for a final time? Or Mohana, for that matter, can you see? This is a patient came and we did a X-ray abdomen erect, and it shows classically something under the right dome of diaphragm. So another case of crescent sign with a gas under the diaphragm. And this is the last thing. Sometimes, even though for appendicitis we do ultrasound as a first line of investigation, in abroad, especially United States, or even in our country in a difficult cases, a CT abdomen is the investigation of choice in a difficult case of an abdominal pain evaluation where the patient has right leg fossa pain. If you carefully see, you can see a fecalith in the right leg fossa region in a coronal section. This is a coronal section. Now, all these pictures I am repeatedly putting you just to understand, comprehend. There are coronal section, cross section. Coronal section will give you an idea what we are dealing. This is a cecum, ascending colon, transverse colon, descending colon, sigmoid, like that. This is the distended bladder. This is a appendix going right, trying to enter into the pelvis. Okay, there you can see some couple of radiodense opacities very clearly, and a classical presentation of appendiculolith or a fecalith in the inflamed appendix with a periappendicular phlegmon. Phlegmon is an inflammatory reactions around the umbilicus, around the appendix. So there are CT findings. In other words, I'm keep telling you from today onwards for the next few weeks, you keep seeing various X-rays, various radiologists describe, start to speak the language of the radiologist, then think like a surgeon and read like a radiologist, then you'll be master of the radiology. Okay, with that one, I say bye-bye to all of you. I can see Karmeham nicely relaxing there. Say good, some words of wisdom, Karmeham, before I conclude. One quick word from you. Unmute yourself.
Nothing to add is what to add to you.
No, just one. Something I'm sure you have a lot more to tell. This is, I thought this is the bare minimum. What do you think? Whatever we said is on par, or this is what they should know, or we were overboard? Is it a little higher for the standard? What do you think? What is your expectation? If you're an examiner, do you expect all these candidates should know at least this much?
This class is for a bright student, not for an average student.
Okay. We are making the average student to bright student. That's why I am trying to do. Okay.
Well told.
Okay. So they should not be getting intimidated. Oh, I should know this much. This is sky is the limit in medicine, and this is putting you on the right trajectory. And after all, if you go in a systematic way, it is not too difficult to understand, isn't it, Karmegam?
The X-rays are horizontal beam X-rays and vertical beam X-rays. Horizontal beam X-rays is for the diagnosis of air, pneumoperitoneum.
Yeah.
And the pneumoperitoneum can easily be diagnosed with even the patient lying down.
Yeah, lateral decubitus view. That is called.
Yeah. Supine decubitus.
Yeah, I told you. I mean, there are other additional indirect. They already know supine abdomen like a football sign, regular sign, or if the patient is so painful, not able to sit, you can ask them to lie down, and you can put the thing, the horizontal beam come in that way. That is called the lateral decubitus view. Very well. Yeah, that is an additional point is also well taken, Karmegam. So with that one, we'll bring in some interesting short cases. If you have any interesting short case pictures, you share with me. I can show them also. I'm sure you have some one or two like a melanoma, sebaceous, lipoma, one snapshots of something. You share with me. We put them. We will put them into. Next week is a short case for them. Okay.
Okay. Thank you.
With that, we'll. Okay. Thank you. Thank you. Bye bye.
Thank you. எப்படி நமக்கு வீடியோ போயிருக்க மாட்டேங்குது வீடியோ ஆன் பண்ணிட்டியா வீடியோ வழக்கமா க்ளோஸா தான் இருக்கு கார்மேன் ரிலாக்ஸ் நான் வரல உள்ள